We're having a few technical difficulties. We have a remote presenter and we're trying to get him set up so that he can present remotely. So if you can hang with us for just a few more moments. Thank you. Are we good? You give me the thumbs up when you, is it good? Okay. We're good to go? All right, great. Good afternoon and welcome back to the New Technology Add-on Payment Town Hall meeting for fiscal year 2021. And our first presentation for the afternoon will be Hemospray Endoscopic Hemostat. Dr. Seth Gross will be presenting remotely. So Dr. Gross, you do have the floor. Thank you.
Thank you very much. Good afternoon, everybody. Sorry I couldn't be with you in person, but I wanted to just give you some background of where hemostatic powder, known as Hemospray, is today in endoscopy. Next slide, please. So just for some background points, non-variceal bleeding, which is bleeding, say, from ulcer disease, is very common in the United States, over 500,000 admissions a year. And we do have different modalities to try to stop that bleeding, whether we're using a sclerosant where we're injecting something to stop it, or we put in epinephrine for vasoconstriction. The other tools that we have are cautery and ligation with clips. And there is certainly a tremendous variation of skill amongst the physicians that perform endoscopy to control bleeding, and that's why we do see a 10 to 20% of continued or recurrent bleeding with an associated mortality of 2 to 4%, and we certainly struggle in the area of patients that have malignant bleeding, which, as many of you know, tumors are quite vascular, and it's very difficult to get successful hemostasis in many of these patients, and the rates are quite low, about 40%. We have recurrent bleeding where patients continue to come back to the hospital or they're transfusion dependent, and some of them have very significant bleeding in the first 3 months or so, where the mortality is upwards of 95%. Next slide, please. So Hemospray works a little bit differently than the other modalities that I had mentioned. It's a inert powder that requires active bleeding since it absorbs the water, and it causes this cohesive, adhesive barrier that leads to immediate hemostasis. What's nice about it is it's non-traumatic, it's non-thermal, it's non-contact, and you don't have to be precise. And many times in gastrointestinal bleeding, we definitely have a difficulty with visual field. There's a lot of blood in the area. There's pulsatile blood, and sometimes it's very hard initially to do very fine movements, whether it's thermal cautery or put a clip, and where when you have Hemospray, when we go to the next slide, I'll give you a sense of how it works. So we have active bleeding. You see that in the center of box 1. And then when we apply the Hemospray, you see we're just not going where the bleeding is. We're going at the bleeding site and to the left and to the right of it. As long as we have active bleeding, we get water absorption, and then we get this immediate mechanical barrier that leads to hemostasis with clot formation. Next slide, please. And this is what an endoscopic image looks like. This is in the stomach. It's from our colleagues in Europe. You see on the before, there's some active bleeding, and then you see the during where the hemostatic powder is applied, and you see you get a broad area. So aside from just getting that area in the center where the bleeding is, we can get above or below that, so we get some nice broad coverage. And you see that there's no further bleeding, and we get pretty immediate hemostasis. Next slide, please. And so this is the alternatives for patients before Hemospray in the United States. We would often see repeated endoscopy, where we're bringing those patients back to the endoscopy unit with poor success. The next step after that in most hospital algorithms is to send to interventional radiology, and then after that on to surgery. And urgent surgery, like with anything, urgent surgery never leads to great outcomes. There's a 55% reported morbidity morbidity and a 30% reported mortality. And embolization in itself, has risks to patients, whether it's the contrast dye or, increased risk of rebleeding. And so if we're able to be in a situation where we could actually make endoscopic therapy work when the conventional things like clips or thermal cautery are not working, we could spare these patients unnecessary interventional radiology or surgery. Next slide, please. And this has a tremendous impact on many key metrics for hospitals today, which is managing length of stay and managing additional cost. And if you look to the left of the screen, what you're seeing is what happens after a patient has just one endoscopy, where the length of stay is the shortest. That's that blue part of the table there. Then when you have multiple endoscopies, the length of stay goes up, and you could just imagine if they need more invasive treatment, such as embolization, and the last thing we'd want is surgery, the length of stay just continues to rise. And as that continues to rise, as does our costs. Where if someone has more than one endoscopy, it's over $20,000, embolization about $40,000, and then surgery over $50,000 in additional costs, which could potentially be averted when we use Hemospray. And we're seeing it quite regularly now I work at a huge academic hospital, over 700 beds, and we are using Hemospray to prevent patients needing to go to interventional radiology or surgery. Next slide, please. And so Hemospray has been quite successful for non-variceal bleeding. We have immediate hemostasis, which means during the endoscopy we see no further bleeding, and that as terms of first-line treatment in 88 to 90%. And it's also been successful for rescue when the traditional stuff does not work, such as vasoconstriction. And there's been some good data. A lot of the data that we've seen is outside the United States, just because Hemospray is new to the United States in terms of FDA approval. But we're starting to see those results as well when I talk to my colleagues across the country. Next slide, please. And there was a post-market registry outcome looking to see what happens with immediate hemostasis with monotherapy, which is 92%, combination therapy 88%, and rescue therapy 85%. And I think we're sort of at a paradigm shift here, where outside the United States, Hemospray is being used as a first-line therapy for controlling of bleeding. There are some bleeding scores that we look at, like the Blatchford score or the Rockall score, and that just sort of gives you a sense of like severity of bleeding, but predicting rebleeding rates, where it used to be pre-Hemospray of 25 to 40% for some of these other modalities. We're seeing rebleeding rates of less than 20% depending on the category. So for monotherapy, 7.3%. When we're doing combination therapy, 9.6%. And if Hemospray is being a rescue, it's still getting success at 19.1%, and it's also impacting mortality. So when you have those high Rockall scores of 7 and 8, you see the predicted mortality is quite high, but with the aid of Hemospray, those mortality numbers are significantly lower, under 15% for rescue, and for monotherapy, just under 12%. So you get immediate hemostasis and 89%. And even this year alone, Helio has named Hemospray the Disruptive Innovator Award in terms of a medical technology. So it's definitely getting notice of what it could do for patients and physicians that need help with gastrointestinal bleeding management during endoscopy. Next slide, please. And what about malignant bleeding? When we see this, it is quite challenging. And as I mentioned earlier, these patients tend to keep coming back because they have very friable tissue lining, most of the time because it's infiltrated with tumor. And we definitely have a difficult time of getting successful hemostasis with high recurrent bleeding rates. And if we're able to be in a situation where we're seeing decreased transfusion needs, decreased need for a hospital, allowing patients that do have these types of malignant bleeding to tumors that are not amenable to curative resection, they could keep them out of the hospital, give them better quality of life. And we're seeing a 90% response with Hemospray first line versus 40% standard of care. We see a decrease in rebleeding, which is our biggest challenge, 20% versus 60%, and rebleeding bleeding, 17.1% at first line versus 46.7% when used as a rescue. So it's definitely making tremendous headway when we're dealing with malignant bleeding. So this is a type of therapy that's good for non-malignant bleeding to help someone who's critically ill and unstable and an acute GI bleed, or these patients with malignant bleeding, which could be chronic, or sometimes they also have pretty significant acute bleeding if the tumor invades into a arterial blood vessel. Next slide, please. And when we look at Hemospray versus a standard of care for malignant bleeding, yes, the N is small, but it was able to achieve hemostasis 9 out of 10, so 90% compared to standard of care, which is 40%. And even when the standard of care crossover, Hemospray was able to get hemostasis. And if you look at the 30-day free bleeding rate, which would mean someone would end up back in the hospital, 20% in the Hemospray group versus 60% in the standard of care group, so a 90% immediate hemostasis, and we have not really moved the needle on managing malignant GI bleeding in really decades. So this is a tremendous step forward for the field of endoscopy. Next slide, please. And when we look at some additional data for malignancy outcomes, again, it's pretty clear. There's 94% achievable immediate hemostasis. I'm not going to go line by line, but you can see that the data is, quite compelling. Next slide, please. So just in summary, gastrointestinal bleeding is a very common condition that we face, oftentimes in the middle of the night. And if we don't get early hemostasis, there's a high risk of rebleeding, which impacts patient length of stay, getting more invasive procedures, and certainly impacting on cost. We know that interventional radiology and surgery not only has additional costs, but there's increased morbidity, mortality associated with it. And we've seen that Hemospray can achieve immediate hemostasis for those that fail standard therapy. And it is probably moving towards a first-line treatment option in this country for patients with recurrent bleeding due to malignant lesions. So I would really hope the committee looks at this seriously to consider giving us some sort of reimbursement support so we could continue to offer this to our patients. And I'm happy to take any questions. Thank you. I think that's the end.
Okay, seeing no questions in the auditorium, are there any questions on the line? Moderator, may you open the telephone lines, please?
All lines are now unmuted.
Do we have any questions on the line? Okay, hearing none, I do see that we have perhaps a question in the chat. A potential Hemospray question. If the medical officer, okay, I'm sorry, how is this product different from other existing FDA-approved technologies such as EndoClot?
Okay. My name's David Wagner. I'm the medical liaison for Cook Medical. As far as we know, unless this has happened quite recently, EndoClot is not FDA approved in the United States. So there is no competing technology.
Thank you for that response. Any other questions? Okay, it looks like we have no further questions. Thank you for your presentation, Dr. Gross, if you're still there. Okay. The next presentation we have on the agenda is ZULRESSO, and we have Dr. Koji Takahashi here to present for ZULRESSO. Welcome. Your slides will load, and then you'll be able to.
Okay. Good afternoon, and thank you, everybody. My name is Koji Takahashi. I'm an Associate Director of Medical Science Liaisons at SAGE Therapeutics. And today, I'd like to start by giving an overview of postpartum depression, the current treatment landscape, before going into our clinical trial data supporting the use of ZULRESSO, the first and only approved medication specifically indicated for the treatment of postpartum depression in adults. So to take a step back, postpartum depression is one of the most common complications during and after pregnancy. So more common than commonly understood complications of childbirth and pregnancy, such as diabetes, hypertension, and postpartum hemorrhage. Historically speaking, postpartum depression has been an understudied, under-recognized, undertreated condition. But if we look at prevalence estimates from the CDC, we see that on average there's about an 11.5% of new moms that are affected by postpartum depression each year. This is really in line with other national statistics as well. Importantly, the timing of onset of postpartum depression can vary from case to case. Sometimes it happens quickly after childbirth. Other times it appears months afterwards. And what's important about that is that postpartum depression might occur outside of the bundled care of traditional labor and delivery. So this often represents a separate treatment encounter for these moms. Postpartum depression is characterized by anxiety, low self-esteem, really, in a nutshell, moms not really being able to feel like themselves. We know from epidemiological studies that untreated postpartum depression can have significant effects on the ability for mothers to bond with their babies, effects on the family unit, and in the most severe cases, self-harm, suicidality, and suicide. And we know that suicide is one of the leading causes of maternal mortality following childbirth. So as a whole, postpartum depression really represents, there's an urgency to treat this condition, given that moms are really in a vulnerable state of their lives and their babies' lives. When we look at the current treatment landscape for postpartum depression, we see that there are both non-pharmacological interventions, such as psychotherapy, cognitive behavioral therapy. There's also pharmacological interventions. And the chart on the right shows commonly used medications, and it's dominated by SSRIs, standard antidepressants, which are not indicated for the treatment of postpartum depression. These are drugs that are traditionally indicated for major depressive disorder. If we look at kind of the meta-analyses for SSRI use, we know that the evidence is lacking in terms of their efficacy in postpartum depression. We also know that SSRIs take on average 4 to 8 weeks, sometimes up to 12 weeks for efficacy to emerge, if at all, in postpartum depression. And oftentimes there are dose adjustments, titrations, sometimes switching medications, which all take time in order for efficacy to emerge. And really, again, what we're talking about is a very acute episode of depression in a vulnerable population, which are moms with their newborns. In addition to the medication efficacy standpoint, postpartum depression also is characterized by other logistical issues. So, for example, finding an appropriate maternal mental health expert that can accurately diagnose and treat postpartum depression, long wait times for referrals, insurance coverage, and again, the aforementioned dose changes and not ideal treatment with the current standard of care, again, which is not indicated for postpartum depression. ZULRESSO is the first and only FDA-approved pharmacological treatment for postpartum depression. We started the investigation of ZULRESSO with a real biological hypothesis in mind. ZULRESSO contains brexanolone, which is a neuroactive steroid. This is a completely different class of molecules than what is currently available. Brexanolone is endogenously identical to allopregnanolone. This is a neuroactive steroid that both men and women have in our brains. And primarily the role of neuroactive steroids is to modulate the GABAergic system, or the inhibitory neurotransmitter system. And we and others in the field believe that this system is really important for the control of depressive symptoms overall. ZULRESSO is a Schedule IV controlled substance. It is supplied as 100 milligram brexanolone in 20 ml single-dose vials containing a sterile, preservative-free, clear, colorless solution. It's administered as a continuous IV product. It's a continuous infusion over a total of 60 hours, requiring titration. So this is 2.5 days. Importantly, what we found in our clinical trials was a low risk, but a risk of sedation and loss of consciousness. And for this reason, it's supplied under a REMS program to really mitigate that risk of serious harm. So there's a lot of data on this slide, and I'd like to just take a little minute to kind of walk you through this. This is an overview of our pivotal clinical trials for ZULRESSO. On the left is our phase 2 randomized controlled trial, and the middle and right columns are our phase 3 multi-center placebo-controlled trials. Our phase 2 trial used a dose of 90 micrograms per kilogram per hour ZULRESSO. Again, this is allopregnanolone, and this concentration was chosen to mimic the peak concentrations of allopregnanolone experienced in the third trimester of pregnancy, so presumably a concentration that we all have been exposed to in utero. We enrolled a relatively small number of patients, 21, with a severe Hamilton Depression Rating Score of greater than or equal to 26. The Hamilton Rating Scale is a gold standard in terms of clinical trial design and measuring depressive symptoms over time and with an intervention. So a score of 26 and above is considered severe. A score of 7 or below is considered remission. What we found in our phase 2 trial was at this dose that moms in the active arm had about a 21-point drop in their Hamilton Depression Rating Scale. So on average, going from 26 and above to less than 7, indicating remission of symptoms. We replicated these studies in larger phase 3 trials. Study 1 studied same patient population, severity of 26 and above, but looked at 2 different doses, a 90 microgram per kilogram dose and a lower 60 microgram per kilogram hour dose. Study 2 studied the same dose, 90 micrograms, but we studied a more moderate patient population. In all of these studies, ZULRESSO was statistically significant to placebo. We found significant drops in Hamilton Depression Rating scores compared to placebo, and importantly, these were found at the primary endpoint, which was at 60 hours, 2.5 days post-delivery. What's important about that is, again, about a quarter of the patients that came into our study were already on antidepressants and qualified for the study with a Hamilton Depression Rating Scale of 20 to 25 or over 26. And within a very short amount of time, these moms found very rapid resolution and durable resolution in their depressive symptoms. As I had mentioned, ZULRESSO is an intravenous infusion, and it's also under a REMS program. Given these considerations, there really requires a multidisciplinary approach. Healthcare settings need to be certified under the REMS program, various requirements in terms of patient monitoring and safety. The pharmacy and the site of care needs to have an ability to procure and prepare the compound and infuse the compound. And really, it takes, again, a multidisciplinary approach to be able to deliver this novel and really groundbreaking medication. Since the inception of the ZULRESSO REMS program, we've seen about 60% of enrollees being in the hospital setting, patients being split between usage in the inpatient and outpatient settings, and about 40% as a non-hospital or alternative site of care. So in summary, I'd like to just go over the qualifications for our NTAP, the newness, cost, and clinical significance. Again, ZULRESSO is the first and only approved medication for postpartum depression. Its mechanism of action is differentiated compared to anything else that's on the market. It was approved in March of this year and commercially available in June of this year. Considering the cost, the standardized charge for ZULRESSO is $225,056, which greatly exceeds the cost criterion and meets the cost criteria. And when we talk about clinical improvement, again, this compound was given breakthrough and priority designations by the FDA. It's the only approved treatment for PPD. And as I had shown in the clinical trial data, what we see is a very rapid and durable reduction in depressive symptoms at the primary endpoint. Thank you, and I'll be happy to take any questions. Yes? Hi.
From CMS. So the Hamilton scale is taken again at hour 60.
That's right.
Is there any evidence? Hi, I'm Tahila from CMS.
Hi.
The Hamilton scale is taken again at hour 60. Is there any evidence of how this was maintained over time?
Yes, so our primary endpoint was at hour 60. We followed moms up to day 30, and we found durability in that response and a very low relapse rate for moms that responded at hour 30. 94% did not relapse at the day 30 mark.
Thank you.
You're welcome.
Any additional questions in the auditorium? Okay, moderator, will you open the line for questions, please?
All lines have been unmuted.
Do we have any questions on the line?
Hi, this is Karen Nakano from CMS. Can you hear me?
Yes, we can hear you, Dr. Nakano.
Great. So, quick question for you. You took your studies out to 30 days. Are there any plans to take it further in terms of understanding the long-term effects of this treatment for postpartum depression?
Currently, not at this time.
Okay. And then second of all, you had mentioned that in your studies, these moms had been on multiple other antidepressants. Once you had them in your trial and ZULRESSO was given, did they continue the other antidepressants or did they come off of them?
Yeah, so ZULRESSO was designed as a concomitant add-on medication. And so we found that there was no difference in terms of efficacy, whether they were on antidepressants or not. And in the follow-up period, patients were allowed to come on and off antidepressants in that follow-up period.
Okay, thank you.
Do we have any questions in the WebEx? No, it looks like we don't. Thank you, Dr. Takahashi.
Okay, thank you.
Appreciate your time. Our next presentation will be the GammaTile, and Dr. David Brachman is here to present the GammaTile.
Good afternoon. My name is David Brachman, and I am a radiation oncologist and the Chief Technology Officer at GT Medical Technologies. We'd like to thank CMS for the opportunity to present today. And as a quick overview, I will be discussing three things. The first are the current challenges associated with treating recurrent brain tumors. The second is the GammaTile, a therapy which we believe is a solution to several of these challenges. And the third is the clinical data behind this statement. Basically, aggressive brain tumors often reoccur, and in large part because brain tumor surgery, unlike surgery on tumors elsewhere in the body, is rarely done with a wide enough margin to remove all surrounding tissue to eliminate all possible tumor cells. Adjuvant radiation treatment is often utilized as a substitute for a wide surgical margin. These radiation treatments are typically done by a machine which directs powerful radiation beams from outside the body aimed inward. And these are termed external beam treatments. They are sometimes completed in a single day, but are typically requiring outpatient visits over 3 to 6 weeks. And they can be useful, but their effectiveness is lessened by a 2 to 3 week waiting period after surgery for surgical wound healing to take place, a time during which the tumor cells can often regrow. And they also expose large amounts of normal brain tissue to the potential for radiation injury. A key point here is that when brain tumors reoccur, external beam treatment is rarely done a second time out of concern for radiation-related brain injury. The lack of a safe and effective adjuvant treatment, without which tumors often grow back quickly, often during the surgical healing period, without this, many patients are turned away from a needed surgery, and that was the impetus for the development of the GammaTile. This schematic shows the location of the 4 cesium-131 radiation sources within a GammaTile and the design of the tile, which ensures a structural offset of the sources from all surrounding tissues. The GammaTile is permanently implanted, and the high-activity, short-range cesium isotope used allows for a rapid but localized treatment, and we have been granted 18 utility patents to date for this. This is a photograph of an actual GammaTile. I tell people that just like a vial of penicillin, it doesn't really look like much. Each tile is a 20 by 20 millimeter square, 4 millimeters thick. It's made out of a collagen construct, and the radiation sources are embedded at precise locations, structurally offset from the brain on all sides. The blue dots you can see in the vertical tile are strands of suture that are used to pre-position the radiation sources, not the sources themselves. This would be a video, but I think we're viewing a PDF, so I don't think it's going to play. And it's a 30-second image that we'll talk more about taken during the clinical trial and shows tile placement in an actual brain tumor resection cavity. The at-risk areas of the brain lining are lined or tiled with these devices, and the devices themselves do not swell when hydrated, are self-adherent to brain, and are monotherapy. And I'm so sorry you can't see it, especially after lunch. As a brief recap, the GammaTile is a surgically targeted therapy which is permanently placed at the time of inpatient brain tumor surgery, allowing the start of radiation treatment immediately, and this eliminates a patient's need for return outpatient radiation treatments. The GammaTile therapy was FDA cleared for the treatment of recurrent intracranial neoplasms of any histology in July 2018. The first commercial use was in January 2019 at the University of Minnesota and is currently being used at 12 centers in 10 states. The full trial outcomes, our GammaTile experience in recurrent aggressive meningiomas was recently published in the Journal of Neurological Surgery, and the full trial outcome results were presented at the American Association of Neurological Surgery plenary session in April of this year and given the Rosenblum-Mihaly Award for the best neuro-oncology research at the meeting. The adverse effects data from the same trial were presented at the plenary session of the American Brachytherapy Society in July of this year and given the Judith Stitt Award for the highest ranking peer-reviewed presentation at the meeting. GammaTile therapy received, nope, that's okay. I'm good there. And before the GammaTile was developed, there was no routinely effective treatment paradigm for recurrent intracranial tumors. It turns out that giving a recurrent brain tumor patient a second chance requires a multimodality approach, which means more than one therapy, and using surgery and GammaTile together satisfies the basic need here. It also lessens the toxicity associated with the current radiation therapy paradigms. The key point of this slide is simply that when a brain tumor does reoccur, repeat external beam radiation is uncommonly used a second time because, as we discussed a bit earlier, the normal brain tissue has received a maximum safe dose of radiation at the time of the initial tumor treatment. The downstream impact of not having an effective and safe repeat adjuvant treatment is that surgeons are often reluctant to offer reoperation even when the patient could benefit. The alternative to radiation from the outside, the alternative to external beam radiation, is internal radiation, also called brachytherapy, and is a technique that places radiation at the site of the tumor and therefore can have less impact on normal tissues than when beams pass through from the outside. Brachytherapy is a standard of care treatment for other tumors, but it is rarely undertaken in brain tumors today, and the reason for this is that until now the drawbacks have outweighed the usefulness. This image shows the post-operative CT, the far left slide, from the patient in the video, and the white arrows indicating what a C looks like on the CT. The middle image compares and contrasts the much larger areas of brain impacted by external beam radiation treatment with the smaller volumes on the right image from impacted by the GammaTile. In each image, the area in need of treatment is inside a thin white line showed at the white arrow, while the colored areas show the extent of the tissues that are actually impacted by the radiation treatments. Because the GammaTile treatment limits the adjacent brain impact, retreatment with radiation becomes an option for some patients, and thus allowing the possibility of reoperation. This slide shows the two main ways brain brachytherapy was done before the GammaTile. On the left side, the 6 silver cylinders near the dime are radiation seeds, and the silver dots seen in the brain photo are seeds that have been inserted directly into the brain, resulting in direct tissue contact. This direct tissue contact always results in areas that are toxic to brain at doses that are more than 20 times above what are needed to kill tumor cells, and is one of the fundamental problems with this technique. The two images on the right are photographs of another available device, one that uses a ball-shaped X-ray tube that needs to be maneuvered into the operative cavity. Both treatments suffer from significant mechanical shortcomings, and both add significant time, typically in the range of 30 to 45 minutes or more, to the basic operative procedure. This results in increased anesthesia time, as well as staph radiation exposure. These are some of the reasons why brain brachytherapy has remained a rarely used approach. As a quick recap, the GammaTile's advantage are a structural offset, which protects brain tissue from excess radiation. It integrates easily into the surgical workflow, adding typically 6 minutes or less to the end of the procedure, and it enables immediate treatment at the time and place of the resection with no additional hospital stay. And it ensures 100% patient compliance without the need for additional outpatient visits. We're going to jump into the data behind some of these clinical trial statements. This is the same patients that presented at the AANS meeting earlier this year and consisted of 79 recurrent tumors in 74 patients and included recurrent high-grade gliomas, meningiomas, and brain metastases, along with 4 other histologies. The trial design was prospective, single-arm basket design. All patients had failed radiation at least once before, and the average number of prior same-site surgeries was 2. The treatment was maximum safe resection and GammaTile placement, and the endpoints were local control at the treatment site, overall survival, and complications. No patient received additional same-site local treatment unless they failed, and systemic treatments were done at the treating team's discretion. The median follow-up was 16.4 months, with a range of less than 1 to 54. Considering all treated tumors together in the study, the median local control was 19.9 months versus the local control with the prior therapies of 10.2 months, with a highly significant hazard ratio and p-value. Breaking it down by specific tumor types, local control after surgery and GammaTile was compared to the prior standard of care treatment received by the same patients. Median local control for high-grade glioma patients after surgery plus GammaTile was 12 months versus 9.5 months with the prior treatments. For meningioma patients, local control was 48.8 months versus 23.3 months with the prior treatments. And for metastases patients, the median local control had not been reached versus 5.1 months with prior treatments. Thus, the improvement in median local control times compared to the prior standard of care treatment was seen across all groups, with this being greatest in the meningioma group, followed by the metastases cohort. We're going to skip the next 2 slides. In terms of overall survival, the median overall survival after surgery plus GammaTile was 12 months for high-grade glioma patients, 12 months for brain metastases patients, and 49.2 months for patients with aggressive recurrent meningiomas. These are very reasonable outcomes for recurrent brain tumors. For a little more clinical context, the typical meningiomas treated on the study would have been unable to be treated by the other available brachytherapy treatments, either because of the size or location in the brain, and were often considered to be either poor candidates or wholly ineligible for external beam radiation. Despite these adverse patient selection factors, as shown on this graph, patients treated with surgery plus GammaTile exceeded the outcome seen with the prior best available therapies, achieving a median local control after surgery plus GammaTile of 48.8 months versus the 23 months with the prior treatments as discussed. For patients with brain metastases, preoperative size is one of the most important predictors of treatment failure. Typically, tumors 25 millimeters or larger have much poorer local control rates than smaller lesions. This table illustrates the local control outcomes at 1 year with the commonly available used treatments, and GammaTile appears to improve on the current standard of care for larger brain metastases without the toxicity widely associated with whole brain radiation treatment. With reference to high-grade gliomas, this bar graph shows survival outcomes after surgery plus GammaTile compared to literature-derived values for other available options for recurrent high-grade gliomas at 6, 12, 24, and 36-month time points. The taller green bar represents the current study outcomes, the bluer bar treatment with the Optune device, the lighter green bar chemotherapy, and the gray is best supportive care. As with the meningiomas we treated, the gliomas treated on the study were typically also unable to be treated with the other available brachytherapy or EBRT modalities because of location or size. With surgery plus GammaTile, we were able to achieve very high and effective radiation localized doses, and while not a true head-to-head comparison, these outcomes illustrate the relative effectiveness of the available treatments and the clear need to continue to try and improve outcomes for this cohort of patients. We presented both the surgical and radiation adverse events from the 79 tumor trial at this year's American Brachytherapy Society meeting. Surgical AEs were benchmarked against a 2012 meta-analysis in patients undergoing complex neoplasm surgeries without radiation. Those AE types we did observe were at rates comparable to the rate described for surgery alone, and the majority of AEs described in the meta-analysis were not even observed on our study. I'm going to skip the next slide. Radiation adverse events were defined by CTCAE criteria with follow-up over 4 years for some patients. We had no grade 5 events, and no patient required surgical intervention for radiation brain injury. Skipping the next slide. GammaTile therapy is fundamentally different from all available current radiation treatments. It is permanently placed at the time of surgical resection. The GammaTile device has a structural offset which protects sources of brain tissue from the direct impact of the sources. It conforms to any operative size or shape with precise, accurate source spacing and delivers targeted radiation during the vulnerable time of tumor cells when they are at their lowest population number. In addition, since it's delivered at the same setting as the surgery, it increases treatment compliance, assures access to care, and reduces subsequent physician visits. All indications are that the GammaTile therapy comes very close to doing what we set out several years ago in development, about 10 now, which was to expand the currently available treatment options for recurrent but technically operable patients being turned away from surgery for lack of effective postoperative adjuvant therapy. In summary, these data clearly indicate the GammaTile's efficacy and safety while reducing a patient's care burden, and I thank you for your attention.
Good afternoon, Dr. Periani from Strategy. So question for you for the data. I know you've got several histologies that you're looking at, with gliomas and mets, with multiple histologies. So really the question is there, and most of the data looks retrospective comparison to historical data. Is there any study looking at GammaTile compared to surgery plus SRS, which would be considered the standard gold treatment today for external beam radiation therapy, not IMRT or whole brain therapy for, say, for gliomas. Whole brain would be only used for brain metastasis, multiple brain metastasis, which I think would be difficult to do GammaTile in any way if you had multiple metastasis. So tell me how you stratifying your data, if you can.
Yeah, so I was one of the primary authors of a randomized trial on SRS for high-grade gliomas run by the RTOG, right. Now the NRG, which was a negative trial, so that's not the current standard of care for that. They're too big, for the most part, for SRS. You've hit upon a key problem here, which is we really do need to compare histology by histology, and so that's why we utilize the same site, the same histology, the same care team at the same tumor bed with the best available prior therapy. We have deep talks with name brand centers to run an SRS versus surgery plus SRS versus surgery plus GammaTile metastases trial, for example, which is kind of the standard of care for that. And that data will be forthcoming. But again, that's one histology. Right. Meningiomas are a different thing. They're can be treated with SRS or a variety of other modalities. The current NRG NCI-sponsored trial does not use SRS for meningiomas. Happy to discuss it further, but it's a really complicated thing to get at the right treatment. There's not much clinical equipoise on what to be compared to.
Right, and that was my point. There's data is not comparable to what you have out there standard comparing to GammaTile. So what are you comparing to say it extends local control?
We're comparing it to what the patient's care team at a sophisticated center thought was best available treatment previously at the time, which is not very many years ago, within typically, a year to 18 months, that is what we have. The recurrent brain tumor therapy data has never been a sexy topic. I was a professor of radiation oncology. Most people didn't want to stake their careers on it, so it's a little thin. That's the sad part of all of this. Thank you.
Are there additional questions in the auditorium? Moderator, will you open the lines, please?
All lines have been unmuted.
Thank you. Do we have any questions on the telephone line? Okay, hearing none. Do we have any questions in the WebEx? It looks like we do not. We thank you again.
Thank you.
Dr. Brachman, thank you. Okay. Is Dr. Goldman here? Wonderful. Our next presentation is for the Imfinzi technology, and Dr. Jonathan Goldman is here to present. Welcome. You have a clicker there.
My name is Jonathan Goldman. I am an associate professor at UCLA, where I am the director of clinical trials in thoracic oncology. I've been asked by AstraZeneca to speak on the use of durvalumab for the first-line treatment of small cell lung cancer. I wish to disclose paid consultancy work I have done for AstraZeneca, as well as for other pharmaceutical companies, including Genentech and Pfizer. Small cell lung cancer represents about 13% of lung cancer cases. It primarily affects the elderly. It metastasizes early and can grow so quickly that in some cases its doubling time can be measured in days. Standard chemotherapy with a toposide and a platinum agent helps most patients early on, but within 3 to 6 months, many have disease progression. Patients often present quite sick and requiring hospitalization. Patients may have shortness of breath, painful bone or liver metastases, spinal cord compression, or brain metastases with seizure or other symptoms. In other solid tumors, we would often stabilize a patient and then plan to start chemotherapy in the outpatient setting. However, in small cell lung cancer, with the expected excellent response to treatment and the known inexorable worsening without treatment, guidelines and standard of care indicate immediate inpatient care, even if a patient is bedbound or nearly moribund, because of the excellent expected response with treatment. The standard therapy has been etoposide and platinum for more than 3 decades. Over these years, several other regimens have been tested unsuccessfully until the addition of immune therapy drugs like durvalumab. We know that sometimes the immune system is trying to fight the cancer, but cancer cells have hijacked a system to turn off the immune system called PD-L1. Durvalumab blocks PD-L1, thereby turning off this turn-off switch and allowing the immune system to fight the cancer. Several years ago, I reported on a small but meaningful benefit to durvalumab alone in small cell lung cancer. However, the true benefit comes when we add durvalumab to chemotherapy. The Caspian trial demonstrated that. It's a randomized phase 3 global trial where patients received either etoposide and platinum or etoposide and platinum with durvalumab. A third arm included 2 immune therapy drugs, but the data from that arm has not sufficiently matured, so it has not been analyzed, and I will not be discussing it today. On the chemotherapy alone arm, patients received up to 6 cycles of chemotherapy before entering a surveillance watch and wait phase. On the durvalumab, patients received durvalumab with chemotherapy for up to 4 cycles and then continued on maintenance durvalumab alone. The primary endpoint of the trial was overall survival. We also plan to look at progression-free survival, quality of life, side effects, and tolerability. You can see that the arms of the trial were well balanced. And here we have diagrammed the overall survival. After an initial benefit of chemotherapy, the lines split meaningfully and statistically. There is almost a 3-month overall survival benefit on the durvalumab arm. Important to patients, as I described, to my patients, at 1 year, they have almost a 14% higher chance of being alive for having received durvalumab from the initiation of treatment. Progression-free survival also shows that after the initial benefit to chemotherapy, cancer progression is delayed by using durvalumab. We measured quality of life on 2 scales, a patient functioning and a patient symptom scale, and measured the time to deterioration. All of the point estimates are to the left of 1, demonstrating that the use of durvalumab maintained quality of life compared to patients that did not receive durvalumab. Adverse events are also reassuring in that there's no significant difference between the 2 arms, whether you look at all adverse events, high grade, or serious adverse events. The only difference is in the immune-mediated adverse events. As would be expected, the trial arm that included immune therapy had increased immune-mediated adverse events. These were primarily grade 1 and 2, mostly thyroid dysfunction, which could easily be managed. In summary, small cell lung cancer is a rare but highly aggressive form of lung cancer, primarily affecting the elderly and often presenting with patients that are quite ill and not uncommonly in the hospital. Adding durvalumab to standard chemotherapy significantly improved overall survival as well as quality of life without the cost of significant adverse events. Therefore, adding durvalumab to chemotherapy is an important new treatment option for our patients, and beginning treatment as soon as possible is important to achieving that benefit. Thank you very much. I think I've ended a little early, and I'm very happy to take questions.
Hi, Dr. Periani, Strategy Gen. Nice presentation.
Thank you.
So a question for you, 2 questions. First is the third arm, and I think I asked you this before also, how long is it going to take before it matures, that data is going to mature?
You know, I don't think we know yet. It's, there was 1 interim analysis that's already passed, and now we're waiting for maturing till the final analysis of the trial.
So there's some caveat, analyzing data when all the data has not been accumulated because you may have stratifying issues with the arm. So I just want to emphasize that the data is still not complete. So it's interim data.
That's true, that a final analysis is upcoming, but right. This met the interim analysis pre-specified endpoints for these 2 arms.
Okay. And then the slide you had, the progression-free survival,
yeah,
it showed the curves looked like they're divergent, but the median progression-free survival is actually shorter for your combined arm versus the chemotherapy alone arm. Can you explain?
Sure. The numbers are very similar. I think 5.1 and 5.4. The best thought on this is that on the chemotherapy alone arm, they received chemotherapy out to 6 months, out to 6 cycles, excuse me. So this kept the cancer under control during chemotherapy, but chemotherapy really cannot be continued past 6 months. And so that's probably where the drop-off begins.
So, and I think the same criticism, not criticism, but same idea could be applied to immunotherapy because that's continued forever, I understand. Is that correct, after the patient?
Until progression.
Until progression, so basically forever until the disease progresses, so.
That's right, but more
so
tolerable.
You're getting the effect while you're giving the drug, and then eventually the tumor learns how to get around it, so.
Right, there are a variety of mechanisms that we presume allow a cancer to escape.
Right.
But meaningfully, the toxicity of prolonged treatment with an immunotherapy allows prolonged treatment and by providing ongoing cancer control without toxicity, without much toxicity, that's a significant advance for patients.
So just to follow up to that, is there any dropout of the ones who are getting immunotherapy continuing after the chemotherapy was completed?
The most common reason for stopping the durvalumab was cancer progression.
Okay, not for patient compliance or side effects?
That's correct.
Okay. Thank you.
Thank you.
Are there any additional questions in the auditorium? Seeing none, moderator, please open the line for questions.
Hi, this is Karen. Can you hear me?
Yes, we can hear you.
Great. I was wondering if you could explain when to use Tecentriq versus your product.
The question is comparing two immunotherapy drugs that have not been compared head-to-head in a clinical trial. So any ability to compare the benefits would be very difficult. I don't know that I can say more than that.
Thank you very much for that. So I was curious, it appears on the surface that both of your products, the Tecentriq and your product, both of these products appear to treat the same type of patient population with small cell lung cancer. Is that correct?
That's right. That's right. They were both trials of first-line small cell lung cancer.
Okay, great. Thank you.
Thank you.
Are there any additional questions on the line? Okay, hearing none. Do we have any questions in the chat? It looks like we don't. Thank you, Dr. Goldman. We appreciate your time. Okay, our next presentation will be the wavelength technology, and Dr. Todd Berland is here to present. Thank you. Welcome.
Good afternoon. Last but not least, my name is Todd Berland. I'm a vascular surgeon. I'm about 10 years out in practice, and the reason I'm standing here today is because 4 years ago, I was the first vascular surgeon in the world to create an endovascular AV fistula using this technology that you're going to see here in just a moment. I have no relevant disclosures. I think it's important to note that I do get a consulting fee from BD, Bard, who owns this technology. I train other physicians on how to create an endovascular AV fistula, and in this setting, I'm here today discussing that with you. I have no stock or equity in this company, and whether or not this is approved or not approved does not affect me in any way. We do believe this offers a substantial clinical improvement, as you will see with the following slides. Surgical fistulas, the gold standard for AV access care, has been this way since the 60s. Originally described in the mid-60s by Brescia and Semino, there's been very little innovation in this field in regards to surgical fistula creation. Now, we do know that surgical fistulas using a patient's own vein is much better than a central venous catheter or a synthetic AV graft. You can see on the bottom, mortality rates are higher with AV grafts and central venous catheters. Infection rates are higher with central venous catheters and synthetic grafts, and patency rates are lower, all favoring surgical fistulas. That being said, surgical fistulas do have challenges as well. Only about 1 in 5 patients initiate dialysis with a fistula. 2/3 of patients are still using a central venous catheter after 3 months. Surgical AV fistula failure rates are high, somewhere between 20% and 60%, and can take months to mature in some patients. And this is, I think, one of the most important points here, that last one. Over 83% of surgical fistulas require at least one reintervention within the first year, typically requiring multiple reinterventions to maintain that patency. So there are high failure rates and long maturation rates and times that can lead to longer central venous catheter dwell times. This is the wavelength procedure. I'm hoping we can get this link to run here as this, let's back it up. The whole presentation is just going through. It just keeps going forward. There we go, right click. Well, hopefully we can get this to work. Okay, let me just describe what you are going to see. So the endovascular AV fistula, and that video is really neat, and I would love for you guys to be able to see this, but a traditional surgical fistula requires 1 or 2 incisions where a vein is transected, swung over onto the artery, and we make an end-to-side anastomosis or connection. If they can get this going, that's great, but I'll just keep talking just out of respect of your time. When we create a surgical fistula, well, sorry, it is a little distracting. We'll see if we can get this going. We've seemed to back out of the entire presentation. I'm sorry? No, I think this is good. I think we just have to play that. Do you guys scroll down? Yeah, so I think it is a little bit below that. For some reason it's, yeah, all the way down. Yep, higher. Keep going. You should see this video link here. Yep. Okay, there we go. So what we see here are 2 wires into the brachial artery and brachial vein. We then thread these 2 catheters that have rare earth magnets that are very strong. They find each other in that artery and vein, they coapt, and then we use radio frequency energy to burn a hole from the vein into the artery. So where we would create a surgical incision, here we've got 2 wires, 2 devices, magnets pulling them together, RF energy burning a 5mm hole between the 2, and now flow going through the artery into the vein, up a perforator connecting to the superficial veins. So that perforator connects to a cephalic or basilic vein. That's great if we could just get the presentation up. Allowing the flow to more often than not be split between 2 superficial veins. A surgical fistula creates a lot of flow in one single vein, allows for some surgical manipulation to get that anastomosis just right, and that's where these differences are much different. If we can go forward to the next slide. I shouldn't have said last but not least. Could we go to the next slide? Okay, there we go. On the bottom left is a surgical fistula, end-to-side anastomosis. The thought is you disrupt the vasa vasorum, or the local blood flow to the vein, and that puts patients at risk for stenosis or narrowing of that vein that then requires multiple interventions to stay open. With the endo-AVF, the wavelength endo-AVF, you have this fistula creation between the radial artery, radial vein, or ulnar artery, ulnar vein in the forearm, as you can see there, flow through the perforator into the superficial venous system. So much different than the surgical fistula. These are the available studies. You could see from screen left, the FLEX study was the original concept feasibility study, looking at just over 30 patients, proving feasibility and safety. Then you move over to the NEAT study, which was published in 2017, expanding the number of patients, expanding the centers, again showing safety and effectiveness of this technology. The EASE study, I was the primary and first author of this study. It was just published in October of this year, again looking at this newer device, but same technology, creating an endovascular AV fistula. The EU post-market study has been completed and the data is being analyzed, and we are waiting to start the US multi-center study shortly. What I'm about to show is a few slides showing the clinical benefits of endo-AVF versus surgical fistulas. First comes down to patency. Wavelength patients had a cumulative patency of over 96% at 6 months, looking at that first study. When looking at that second NEAT study, the expanded study, we found at 12 months almost 70% functional patency and 84% cumulative patency at that 1-year mark. Looking at the combined pooled data for all of these studies, the primary patency was about 83% at 6 months and 75% at 12 months. Comparing all this to that bottom line showing surgical AV fistula patency rates of about 60% at 12 months. So patency rates much better for endo-AVF. Looking at fistula maturation time, turns out when you create a fistula between an artery and a vein, it's not immediately ready for use or cannulation for dialysis. This vein has to mature over some period of time before it can be safely cannulated and used for dialysis. So if you look at the mean time to fistula maturation for the wavelength, that was 58 days in the original study. In the EASE study, which we did, we found the mean time to only be 43 days. And when you look at the meta-analysis and put these together, the median time to cannulation was just over 60 days for the wavelength endo-AVF. Compare that to the surgical fistula median time to first use or cannulation at 108 days. Now, wavelength does substantially reduce CVC dependence over surgical fistulas. Central venous catheter placement per patient year was approximately 0.1 for wavelength and 0.4 for surgical fistulas, presumably because the wavelength endo-AVF fistulas are maturing faster and staying open longer. So you would think there'd be less of a need and use for central venous catheters. If you look at the propensity matched data down below there, you could see that incidence and prevalence of CVC catheters are much lower in wavelength over surgical fistulas. This is probably my favorite slide, and when I'm consenting patients for these procedures, because now we can give patients an option of endo-AVF versus open surgical creation, we are finding much fewer re-interventions in endo-AVF patients over surgical fistulas. The procedural event rate after endo-AVF is somewhere around 0.6 per patient year, and about 3 or more than 3 in the surgical AV fistula creations. What I usually tell patients is who are undergoing surgical fistula creation is that they should expect about 3 re-interventions per year. If you look at the propensity score match data down below, you could see the re-intervention rates side by side, wavelength versus surgical fistula, significantly improved for the endo-AVF over traditional surgical creation. Just like you would think any endovascular procedure over an open surgical procedure, there's no incision, so you're less likely to have an infection. There's a known surgical infection risk for type 1 or clean wounds, and surgical fistula creations are not immune from that infection risk. So endo-AVFs have found to have a 0.02 vascular access-related infection rate per patient year over a 1.2 for surgically created fistulas. And you could see the infection rate in an inpatient and outpatient setting for wavelength versus the traditional surgical fistula. Finally, one of the things I also do on the side is I host a Sirius XM radio show on Dr. Radio where patients can call in, dialysis patients, and any of you are welcome to always call in. We talk about different topics, and whenever we talk about dialysis access, one of the hot topics is wavelength. Now patients finally have an option where for 50, 60 years they were told they were getting a fistula, they were told they were getting a graft. Now they actually do have an option, and this option turns out looks like it's pretty good from a clinically improved standpoint. And when we start chatting about this, and when patients start chatting to each other in the dialysis access centers, they really have this cross-communication, and we can find that the patient satisfaction level is really high. That being said, Dr. Charmaine Locke did an analysis looking at quality of life for endo-AVF versus surgical fistulas, and you could see most of the patients were satisfied. The majority would recommend to a friend. 88% found it easy to use, and only 16% would change their access type if possible. You can see on that bottom left side, that's a surgical fistula with a scar and a lot of flow going through one single vein versus an endo-AVF wavelength case, no scar, no incision, and flow is split between 2 veins, so you tend to not get these dilated aneurysmal, ropey-looking veins. And I will conclude with that. Any questions?
Hi, good afternoon, Dr.
Hello.
Periani. Nice presentation. So a couple of questions. First is, how is wavelength different than ellipsis AVF?
So very different mechanism of action. Ellipsis is, first of all, a 2-stage procedure. So we use ultrasound guidance. The procedure is very different in that you're using ultrasound to guide a needle and a wire through a perforating vein into the radial vein only. Wavelength, you have the option of creating the fistula between ulnar artery, ulnar vein, or radial artery, radial vein. So ellipsis is through a perforator, ultrasound guidance, using heat energy to create a hole that tends to be a smaller hole and requires a subsequent angioplasty procedure during another visit 2 to 3 weeks later. The other issue is that the ellipsis, because it only creates that fistula to the radial vein, it precludes patients from getting a radiocephalic fistula down the road.
Okay. Second is the studies you cited, the NEAT study, they were prospectively done for the wavelength endo procedure, right?
Absolutely.
So, but for the AVF comparison, did y'all use matched historical controls, or they were prospective?
They were propensity matched scoring using the 5% CMS data or the US RDS data for those.
So there's a retrospective comparison?
Correct.
Yeah, okay.
Correct.
So, but there wasn't a prospective comparison. Is the US post-market study, are you all going to do any comparison with the standard AVF?
The details of that are being teased out right now, and so that is not, that's not ready for...
Set yet? Okay.
Yeah.
All right, good. Thank you.
Yeah, thank you.
Are there additional questions in the auditorium? Do we have any questions on the line? Moderator, please open the lines for questions.
All lines have been unmuted.
Thank you. Do we have any questions on the line?
Yes, hi. This is Crystal Simpson from CMS, and I had a question about the wavelength Q. It seems as if you can use this in patients who have the smaller arteries and veins, and I was curious, since you mentioned that you were lead investigator on the E study, how many of those 32 patients had those 2.0 millimeter arteries and veins?
All of them. In fact, that is the indication for use for this procedure, is that a patient, I call it the rule of twos. They have to have a 2 centimeter perforator, a 2 centimeter deep vein, 2 centimeter superficial veins. They all have to have 2. All of those patients did receive, had met that criteria.
Okay. Okay. And then when will the post-market study outcomes be available for your EU post-market study?
I don't have that.
Will you be able to share with those?
Yeah, that should be ready soon. Maybe we could use the follow-up comments to get back with you on that. I'm very anxious to see the results of that as well.
Okay, great. Thank you.
Thank you.
Okay. Thank you for your question. Are there any additional questions on the line? Any through the WebEx? It looks like we have none. And so we thank you very much, Dr. Berland.
Thanks.
Okay. All right. That concludes our presentations for the day. I'd like to take this time on behalf of the CMS staff to thank all of the presenters who came today to present, those who presented remotely. We thank you especially for your flexibility in the changes to the schedule. We'd like to thank our public commenters as well. We ask that you do submit those comments in writing to us by the January 3rd deadline. We'd also like to thank all of our participants who came to listen to the presentations in person, and those who attended via WebEx, YouTube, and telephone. So we thank you all, and again, just one final reminder, all comments are due by January 3rd, 2020. Thank you again.
I want to thank Michelle Joshua for emceeing.
Thank you.
Thank you.
Thank you, guys.